Very good afternoon. Thanks to everyone for being here with us today. I, Ankit Dogra, along with my teammate Mr. Amit Saxena from Medical Services Jagsonpal Pharmaceuticals Ltd, are delighted to welcome you all to the web series on Fertility Updates Improving IVF Success, organized by the Fertility Forum of India. The academic partner for today's program is the Naari division of Jagsonpal Pharmaceuticals Ltd, makers of PRORETRO, 10 mg tablets of micronized dydrogesterone, assisting motherhood, delivering happiness, along with EndoReg, 2 mg tablets of Dienogest for the management of endometriosis and endometriosis associated pelvic pain, and Mifepristone, 25 mg tablets of Mifepristone, a safer alternative to the surgical management of uterine fibroids. Dear attendees, if you have any questions, suggestions, or clarifications, please post them in the Q&A box. Please note this webinar is streaming live on the Facebook and the link has been shared in the chat box. Also note, for future reference, we'll upload this webinar on our YouTube channel, Jagsonpal Medical Insights. Now, let us welcome Dr. Jyoti Malik, the facilitator of the program, to kindly take the proceedings further. Over to you, ma'am.
Thank you so much. Thank you, Jagsonpal. Thank you, Mr. Ankit and Mr. Amit. And this is the third series on Fertility Focus India, and improving health for optimizing outcomes is the focus today. And for this, actually, we are doing more of a holistic approach, that we thought we should focus now on our health after the COVID times have passed, and the COVID that has taught us. So that is why we thought that we could do something. Rather, we have been doing, we have learned all our stimulation protocols, the lab procedures, we've mastered everything. And now we should also look in for more improvement. And I think holistic approach, removing stress, improving mental health, and improving the preconceptional health is something should be the focus now. And our webinar today would be focusing on that, because environmental toxins are there. We have to have the more of to remove the environmental pollutants. We have to even focus on our obesity, lifestyle modifications, and many things will be discussed in the panel by the stalwarts that we have today, because they are stalwarts who are dealing with these things day in, day out, and we would be listening to them and taking their suggestions and their inputs on that. And before that, the first thing that we would be talking on would be mental health, that would be taken by our first speaker, Dr. Seema Pandey. And for this, I would invite my chairpersons, Dr. Manish Banker and Dr. Neeta Singh. Dr. Banker is Medical Director, Nova IVF Fertility, one of the largest fertility chains of India. And he has been awarded BC Rai Award. And he has been on board member of many organizations. So welcome, Dr. Banker, sir, for this today's webinar. And then we have Dr. Neeta Singh, ma'am. Dr. Neeta Singh is a senior consultant professor, Division of Reproductive Medicine, Department of Obs-Gynae, All India Institute of Medical Sciences. So, ma'am, Dr. Banker and Dr. Neeta, ma'am, we would be taking your inputs at the end of the talk after Dr. Seema has spoken, has presented. Can we have Dr. Seema's CV, please? So Dr. Seema, most of us know, and for those who do not know her, she is a director, Seema Hospital, Eva Fertility Clinic from Azamgarh, UP. She has been the president of Azamgarh Obs and Gynae Society, and she has been National Executive Committee member of ESAR. She was also co-chair SIG Fertility Preservation ESAR 2019, and a past secretary of the UP ISPAT chapter, has been past editor of the ISPAT newsletter, and co-authored, co-edited many chapters and contributed in various ART books. with keen interest on infertility, and also running an NGO. So that is something very, wonderful out of the league that she is doing, and has been awarded many Champion of the ESAR Award. So Best Youth Academic Brain IMA State Award, we present Dr. Seema to you, and she would be speaking on a very unspoken topic of mental health. Over to Dr. Seema, please.
Thank you, dear Jyoti, for such a kind introduction. A very warm good afternoon to dignitaries on dais, respected chairpersons, and dear friends. Today, we are going to talk about impact of mental health on IVF outcome. Friends, infertility is perceived as a problem across virtually all cultures and societies and affects around 10 to 15% of couples of reproductive age group. In recent years, the number of couples seeking treatment for infertility has dramatically increased. The reason being, like in this child area, females postponing their fertility as per their career goals, development of newer technologies, and most importantly, because of the awareness tools available through various platforms which are giving them information regarding the treatment development. Parenthood is one of the major transition phase of adult life, both for male and female. And when it is not fulfilled, a wish for child has been associated with emotional sequelae like anger, anxiety, depression, marital problems, sexual dysfunction, and social isolation. Couple experience stigma, sense of loss, empathy, lack of empathy, and they try to be away from the mainstream of society. So what is mental health? Let's talk about it. When we talk about this, wellness wheel is the latest concept of your fitness, which includes your physical, emotional, mental, professional, spiritual, sexual, and social, along with financial well-being. And a person, if is mentally healthy, that person can contribute to the society in a positive manner. As we all know that infertility has been a burden, and out of these infertility people, every 1 in 4 couple recently, it has been reported that is referred for IVF treatment. IVF per se is taken as a stigma, as many of our patients still, they do not want us to tell to their parents or society that they have conceived through IVF. And all these things, they are leading to that increase in baggage, and that is affecting their mental health. When we talk about reproductive health psychology, the psychology of infertility is seen as biopsychosocial spiritual crisis, where level of stresses are like learning that one has a deadly disease. You'll be surprised to know that couples feel more anxious and depressed on account of infertility than chronic diseases like HIV, heart disease, hypertension, etc. And that was really shocking for me. Treatment can be a full-time job, as they have to come to the clinic frequently. They have to report for this report, this investigation, that injection, and all this is giving them a kind of mind-body experience that is always negative. If we look at the biopsychosocial model of health, all these factors, their physical health, their social pressure, and their psychological esteem, all are leading to disbalanced effect of mental health. And that is represented as anxiety, stress, and depression. Why can't I? Yeah. So as I was telling you, that prevalence of, they take it more seriously than HIV, cancer, and heart disease. In one of the studies, it was found that couples who are seeking infertility treatment, they were reported to have 3 to 4 times higher anxiety disorder and 2 to 2.5 times higher chances of getting depressed. And infertility otherwise also has been associated with many kind of changes. And once a couple experience and understands that he or they have become infertile, they go through 3 phases, and that is dawning, endurance, and closure. And at any step, when that is not done properly, that leads to mental trauma. IVF per se, as I was telling you, is a very crucial kind of treatment where there is always a threat of permanent infertility and loss of hope in the couple's mind before starting the treatment. And then once they come to know about the process, they are scared of getting injection on day-to-day basis, those blood draws, ultrasound, and oocyte retrieval. Along the process, they always experience that something may go wrong and there'll be failure. Once they become pregnancy, the chances of miscarriage is always burdening them. Out of all the studies, it was found that oocyte retrieval and the day of beta SCG testing was the most crucial and most stressful day in a couple's life. Along with complex IVF procedure, high treatment cost, as our cycles are not sponsored, they are self-sponsored, along with uncertain outcome lead to anxiety, depression, and mental challenges. Both physical and psychological pressure causes reduction in the quality of subjective happiness of patients who are undergoing this treatment. So how does stress affect people? As we all know that stress works on brain through hypothalamic pituitary adrenal axis, where there is increased secretion of ACTH that leads to increased secretion of cortisol from adrenals. Along with that, this stress gives kind of lifestyle changes. Few people start overeating, somebody is undereating, they adopt to smoking, alcohol, not to mention substance abuse. And these things, they lead to increased reactive oxygen species production in their body, and that leads to oxidative stress to granulosa cell in the ovary. Along with this cortisol, both of them, they decrease the estradiol level inside the granulocyte, which compromises the growth and development of oocyte, and there is deterioration of oocyte quality leading to poor reproductive outcome. Along with that, stress can also disturb the secretion of gonadotropins, and effect of catecholamines have also been noted on uterine and fallopian tube function. Stress also affects immunological process of implantation, so rate of implantation is also decreased. HPO axis can be changed in patients of bulimia or anorexia along with PCOS, and many medications which are being used, psychotropic drugs, they are also said to cause infertility. And not to mention our fertility drugs like Clomid, letrozole, and gonadotropins and GnRH analog, they kind of give different kind of mood swings, bloating, etc. So psychological stresses and their relation to IVF has been studied by many people. In this study, Harlow and colleagues, they had studied the effect of stress on IVF outcome, and they found that there was a sign of hypothalamic pituitary adrenal axis dysregulation, and that led to hypercortisolemia, and there was increased level of prolactin. And they did find that lower concentration of norepinephrine and cortisol both in serum and follicular fluid was found in women who were having positive result. That means norepinephrine and cortisol might be important factor in the complex relationship of psychosocial stress and outcome of IVF and infertility. This beautiful study from down south done by my friend Dr. Kavita Gautam and her psychiatrist Dr. Saraswati Bhaskar, where they studied the stress and depression rates among infertile couples, and they found that around 97.5% of couples, they experience stress, out of which 62% couples reported depression, and women perceived it more than their male counterparts, even if the cause was lying in their spouses. And if one spouse was disturbed, that led to anxiety and depression in the other spouse or partner as well. people who just left their jobs for IVF treatment or infertility treatment, they were badly affected by these things. So it's a beautiful study, and all of us need to do something like that. And we understand how important this mental health and counseling is, because just giving medications and telling them about the disease and chances and statistical figures sometimes lead them to further depression. It becomes like a vicious circle. Let's look at this beautiful study published in 2021, and where they have studied the prevalence of depression and its determinant through a PHQ-9 scoring system. Before I tell about this study, let me tell you what is PHQ-9. PHQ-9 is Patient Health Questionnaire, which is a 9-item self-administered questionnaire designed to screen for the presence of depression according to the Manual of Psychology of America DSM 4th volume. Each PHQ-9 item queries the presence of frequency of depressive symptoms in last 2 weeks, and each item is rated on a 4-point Likert scale ranging from 0 to 3, and the total score comes from 0 to 27. If your score comes less than 5, you are not depressed at all. 5 to 10 is mild to moderate, and 10 has been taken as a cutoff, which is an indicative of depression and have a good specificity and sensitivity to diagnose depression. And this study was done on that ground, where it was a cross-sectional study among 1,500 infertile couple, and depression was measured using this questionnaire. And the mean total score of this population was found to be 7.05 using cutoff value of 10. The prevalence of depression came out to be 30% plus. The significantly associated factors which were statistically significant were being female, as I was mentioning, long infertility duration, and failure of previous treatment and self-cause of infertility were important covariables which were significantly important. In this study, they have found the same thing. Around more than 28% couples, they were having depressive symptoms, and around 40% were feeling anxious in different studies. So these figures are quite stable, and we have to look after this, as mental health is the most neglected part of the treating physician as well as the patient. You will be surprised to know, in this study published in 2018, where they have studied 42,000 of couples undergoing IVF treatment, and they found the rate to be around 35%, and around 9% females, they reported having suicidal thoughts or attempts. So that tells us the severity of the problem, and that all that depression, anxiety, negativity leads to discontinuation of treatment, and not to mention other changes in their lifestyle, like they start overeating, especially females, leading to obesity, alcohol consumption, smoking, and other substance use. As we all understand that obesity is associated with poor reproductive outcome, as COH is really difficult for them, with reduced number of oocyte retrieval, poor quality of oocytes and embryos, and negative endometrial receptivity, the chances of getting pregnant becomes lesser. If you are smokers, if you are a current smoker and undergoing IVF treatment, the chances of failure in terms of pregnancy rate, live birth rate are higher than people who have been smoking in the past. So that is also established. Alcohol consumption more than 4 drinks a week had 16% less odds of live birth rate and even failure of fertilization. So these factors are going to be additional factors along with anxiety and stress, and that is going to compromise your IVF outcome when you are taking these patients without proper counseling and therapy for an ART cycle. Its effect of these problems do not stop here. There were studies where they had studies tried to find out how these couples were feeling 10 or 15 years down the line, and they found that the effect of depression, anxiety due to that infertility treatment remains for years, even when they become grandmoms and granddad. So poor mental health is associated with poor clinical pregnancy rate. Here we have the evidence, two meta-analysis, interesting ones done in 2011 and 2017. I am quoting here. And they have concluded that couples who were having depression and anxiety during cycle, they had lesser chances of success than people who were having it in past and were treated or counseled properly. And depression and state anxiety during ART may have affecting the ART outcome was their conclusion. So need of the hour is ongoing and comprehensive support to the patient undergoing IVF to manage physical and mental health and to reduce the risk of mental illness on fertility outcome. So how do we do it? There are psychological, social, and educational parts of this treatment which we have to take. The moment a couple comes to your clinic, this counseling should be starting long before when you have decided to go for the treatment. And this can be, and you will come to understand by talking to your patient whether this patient is anxious, depressed, or needs counseling or something else. And here starts the treatment. Specific therapies under psychological interventions are cognitive behavioral therapy, which changes your negative conditions and beliefs by doing positive thing, and mind and body interventions to make you relax by acupuncture, meditation, yoga, and hypnotherapy. And educational materials, the most important part of any treatment journey. A patient, the moment he or she comes or they come, the first and foremost thing is giving the information regarding what are they suffering from, what is the course of action we are going to take regarding the diagnosis, regarding the treatment, and what should they expect from this treatment. Until unless we are clear on this platform, this couple is not going to be well informed, and this anxiety will keep prevailing throughout the treatment. So these, if we are doing it properly, this cognitive behavioral therapy along with this information regarding the disease and treatment process and positive relaxation techniques helps these couple to build confidence and hope and improve their mental health. In this, once you have done all this counseling and therapy, it was seen that there are positive outcomes with psychological interventions in patients undergoing IVF treatment. Look at this Cochrane review to 2016, which has included 16 studies, and 7 of 12 studies reported that psychological interventions are associated with less psychological distress, higher pregnancy rate, and improved marital satisfaction. And it was quoted that couples who undergo positive psychotherapy, there are 2 times more chances of them getting pregnant through IVF after we control all the variables. Though there are different school of thoughts, people who think that these therapies do not affect positively the outcome in terms of oocyte quality, embryos, live birth rate, pregnancy rate, clinical pregnancy rate, those are talking just about the physical part of mechanical part of the infertility journey. They are not looking at this couple holistically and giving them some positive hope. Let's have a look at this study published in 2021, where they have studied the effect of acupuncture on mental health of the patients who underwent IVF treatment. They noted that acupuncture improved chances of pregnancy, It increased their coping, resilience, and self-efficacy in the situation of infertility and medical treatment, and was associated with significantly less anxiety these couples experience while undergoing the treatment, and their optimism, calmness, peacefulness, mindfulness, and feeling good within and about themselves was increased. Moreover, this therapy gave them coping mechanism to deal with negativity and positivity equally. So there is a program called the Mind Body Program for Infertility, which was created in 1987. It includes two sessions of cognitive behavioral therapy in a form of it is a form of psychotherapy which is proven to be successful in reducing stress, providing patient with skill in CBT, and increasing pregnancy rates and dealing with all these lifestyle changes they are undergoing. And as I was telling, this systematic review and meta-analysis, which has included 39 studies, was published in 2015. And they found that women who receive some form of psychosociological intervention are approximately 2 times more likely to become pregnant. So friends, if you have time, get connected to your patients at least for 5 to 10 minutes before starting the treatment and try to build that connect. And that is something which is going to do wonders and going to go longer way. Apart from that, how do we do it? Mental health counseling for IVF patients should be a norm for every IVF clinic. And aim should be to explore, understand, and resolve issues arising from infertility and infertility treatment, and to clarify ways of dealing with the problem more effectively, as none of our treatment promises 100% result to the couple. So they'll have to accept that and be ready, be prepared to deal with it. Psychosocial care and psychological help for infertile couples or individual is seen as a stepwise process. It should be patient-centered, infertility counseling, and psychotherapy. Patient-centered in terms of information gathering and analysis, as I've already mentioned, that they should be told about the disease, its diagnosis, treatment, and expectations. And they should be helped in making an active and known a decision where they also understand what are they talking, what are they going for, what are the expectations they have to have it. Support counseling and crisis counseling should be going on along with the treatment so that they understand what is going on, and if some crisis comes, they are ready to deal with it. If you have found that this particular couple or a partner is really depressed or needs therapy, their crisis counseling and therapeutic counseling comes into play, and that should be provided through a multidisciplinary approach. If you don't have time, please have one counselor who can dedicate their heart or his time with these couples. Even ASHRAE has recommended a few things for psychotherapy and mental health well-being in ART patients, and they have quoted that psychosocial care should be individualized or tailor-made for a specific infertility treatment stage and couple, and that should be started long before the treatment or ART is being commenced, before treatment, and it should be continued even after the treatment. Even FOXI has recognized the importance of mental health and psychological well-being, and they have also recommended few things like in preconception stage, psychosocial issues, whatever this couple is facing should be recognized, and they should be counseled and treated if there is reason, and they should be told about the implications of those diseases, like adolescent depression is associated with an increased risk of miscarriage. Preconceptional psychotic or bipolar illness significantly increases the risk of postpartum psychotic or bipolar event, and there is an increased risk of relapse during pregnancy. And fetal teratogenicity is increased if they are having few drugs which are psychotropic. So they should always be counseled to change over the treatment. All those teratogenic drugs should be stopped. And if needed, they should be referred to an expert, as I have mentioned that the approach should be multidisciplinary. So before I conclude my talk, dear friends, I would like to say infertility is really a painful journey. We as treating physicians, we have this responsibility or onus to make them comfortable by our words, by our deeds. And if we cannot do it, we should take help of people who are expert in this. Disappointment, frustration, anxiety, and fear have been reported to be the most prevalent emotional and psychological problems in couples with infertility. Poor mental health is associated with reduced chances of pregnancy in women undergoing IVF treatment, and women who receive some form of psychosocial intervention are approximately 2 times more likely to become pregnant. Current guidelines support the use of psychosocial interventions for managing the emotional and mental health of patients undergoing IVF and to reduce the risk of mental illness on fertility outcome. So our job doesn't end by making them pregnant, dear friends. Our job is when they are smiling with that pregnancy, and even if they did not conceive, they are able to cope up with this situation. Thank you so much for your patient hearing.
So that was wonderful, Dr. Seema. Absolutely amazing talk. Dr. Neeta, ma'am, if you're there, I would like you to please comment on that.
Sharda, ma'am.
The talk was absolutely great, and this is need of the hour. That the facts are that in case if their patient is stable, psychologically absolutely stable, then the chances of IVF success becomes double. That's the beauty of it. And I find, this is very, very important, but she has to be 100% positive, or I think I should say 120% positive about her pregnancy. In case if she's not so, she must be told right in the counseling itself that things are not going to be all right. You can take it easy. My best wishes to you, Dr. Pandey, again, for whatever you are contesting. It'll be great success for you.
Thank you, ma'am. It is needed. Your blessings are.
The organization.
Yeah. Dr. Neeta, ma'am.
Yes, I'm there. I'm there, Jyoti.
Yeah, now we can see, ma'am. Your comments, please, ma'am.
Yeah, it was a wonderful presentation, Seema. And you have highlighted the importance, which Sharda ma'am was also told, that it is high time, especially in the post-COVID era, when already the stress is so high, the mental stress and the mental health is really, really important. And on top of that, you are infertile, undergoing IVF treatment, whose success is not in the hand of neither the physician nor the patient. So what difference mental health can make to the treatment is fabulous, which you have shown by multiple papers. You have shown and shared the studies that if you are you spend little more time with your patients, try and make them understand what this treatment is. And if they are stressed, they are going to, sort of reduce the chances of getting to pregnancy. I'm sure they will understand, and you can make them, incorporate some other programs like the meditation, yoga, and some breathing exercises to relax their mind. And you can employ a counselor who can also look after their psychosocial health and talk to these patients, because these patients are really stressed and they cannot share their anxiety and depression with anyone. They don't want to tell anyone they are undergoing an IVF treatment in particular clinic. They come hiding because no one should see that they are going to a treatment to a clinic. So it is only the doctor and the team who can, discuss and calm the patient and provide a psychological support. So absolutely fabulous presentation. And as Sharda ma'am said, I also wish you good luck, whatever you are contesting.
Yeah, and I'm still on this talk. It's in making. So I'm just improvising.
Okay. Thank you so much. Thank you, Neeta ma'am. Thank you, Dr. Sharda Jain ma'am, and wonderful, wonderful, very illustrious presentation. I don't think it still needs. It's an ongoing thing, but it was absolutely wonderful. Covered everything, and that you said that it should be a norm for all the IVF centers to look into the mental health of our patients. So coming on to the next talk by Dr. Nandita Palshetkar ma'am, though I think she's traveling and she may join us in between, but she has sent a recorded talk, and for that it is my proud privilege and pleasure to invite our chairpersons, Dr. Sharda Jain ma'am. Dr. Sharda Jain ma'am, I think she's the greatest teacher of teachers. She has been teaching for 2 decades in various medical colleges, renowned medical colleges of India, PGI Chandigarh, Lady Hardinge Medical College, and she has made a mark for herself in Delhi via DGF, the Delhi Gynae Forum, which has now has nearly 8 branches all over Delhi, and everybody is trying to learn daily. Each day is a day of new learning and sharing that knowledge. And ma'am is the director, Life Care Center, Life Care IVF. Thank you so much, ma'am, for joining and for also giving us the support that you are there with us all the time. And then we have our second chairperson, Dr. H.D. Pai sir. Dr. Pai sir is a person who needs no introduction at all. Sir is the incoming FOXI president. He's medical director, Bloom IVFs, and I will just, the honors that he has been awarded are stupendous. So a person, a larger than life, I would say he is a person that Dr. Pai is what I can say for him. And I think sir would be joining us soon. And so I would, can you please stop here, Ankit, so that I can start my screen, my PPT. So Dr. Nandita Palshetkar ma'am, she is eminent IVF specialist, more than 30 years of experience, a medical director, Bloom IVF, heading 7 centers all over India. And she's specialized in the world famous IVF unit in Belgium, Italy, Melbourne, and is a pioneer in many technologies, ICSI, laser hatching, blastocyst culture, spindle view, oocyte, embryo ovarian, whatever new comes to India, has actually mastered that and brought it in. And ma'am has been a FOXI president, a president AMOGS, MOGS, IAG, and president-elect ESAR. So I would...
Good evening, everybody. I would like to thank the YTP committee for involving me in this webinar. Thank you, Niharika. Thank you, Jyoti, for inviting me for this talk. I think fertility preservation is something very close to my heart, and I love to talk to people. And this is something which every gynecologist should do. You know, with the changes that have come about in IVF, especially the technology of vitrification, what happens is you can preserve your fertility when you're 25, 30, 35 years old, and then you can have a baby later on when you need it. So it is a beautiful technology which we can actually use in our lives in a lot of patients. And if you look at the different variety of indications, it's really amazing, because there are certain group of patients who are at the risk of premature ovarian failure. Those are, of course, those cancer patients who go for chemotherapy, radiation, or even bilateral oophorectomy. Then genetic diseases such as Turner syndrome, we know that they have a tendency for poor ovarian reserve. Then endometriosis, because endometriosis by itself causes this problem. SLE treatment with toxic drugs, ovarian surgery, repeated ovarian cysts, and idiopathic POI. The other indications are fertility preservation, like delayed childbearing, for social reasons like career, late marriages, not finding the right partner, or history of early menopause in the family, ovum donation programs for ovum banks, and different clinical situations in ART, such as OHSS, semen samples not available, low responders, inappropriate endometrial thickness, and ethical considerations and legal restrictions about embryo freezing. You can do oocyte cryopreservation. So let's look at the most commonest thing which all of us gynecologists face, endometriosis. In endometriosis itself, I tell in each and every of my talk that please do AMH as soon as you see a patient of endometriosis. Let her be 16 years old, 17 years old, 18 years old. So even in adolescent endometriosis, you have to remember that endometriosis reduces the ovarian reserve. The disease itself causes a reduction in ovarian reserve. And that is why it's very important to monitor these patients. And especially if you've done a cystectomy after endometriosis, especially in adolescent patients, I would give her a suppressive therapy till she gets married, or fertilizes, or even preserves her eggs. I have a lot of adolescent endometriosis patients who have preserved the eggs in their 20s, where they've gone on to get married later on, and the disease has progressed, and they have used these eggs. In fact, there's a beautiful paper by Anna Coco where she says the girls have actually come back and used the eggs to have a pregnancy later on in their lives. So cystectomy for any reason, for endometriosis, for benign ovarian cyst adenomas, for dermoid cysts, especially in endometriosis, it does cause a reduction in AMH, and as high as 40% drop is seen when you do a bilateral cystectomy on the ovary. So remember, these are the patients where cryopreservation or fertility preservation can be offered to these patients before going in for surgery. Non-endometriotic cysts, as I mentioned before, dermoid cysts, benign cyst adenomas, these keep recurring. And also, if it's not recurring, the excision itself reduces your ovarian reserve. And the recurrent ones, you must advise them that they must preserve their fertility, because by doing repeated surgery, we also know that be it endometrioma, be it cyst adenoma, be it dermoid cyst, the ovarian reserve is completely destroyed by recurrent surgery. Another commonest form of problem in our practice as gynecologists is tuberculosis of the genital tract. And when we have tuberculosis of the genital tract, it does affect the ovarian reserve. And this was a beautiful paper by Nalendra Malhotra in 2012, which actually showed that the antral follicle count reduced after tuberculosis infection of the genital tract. And definitely, if your patient has tuberculosis, according to J.B. Sharma's review, it's a paper which shows that if you give ATT or anti-tubercular treatment, then there could be improvement in the ovarian reserve. So remember, if you can pick up tuberculosis, genital tuberculosis, and treat it, it will help your patients. But these are the patients, if you find them that they have tuberculosis at a very young age and their ovarian reserve is compromised, it might be, it's an out-of-the-box thinking that you can offer fertility preservation to them at a young age of 26, 27 and ask them to preserve their fertility. You won't believe it that this thought of out-of-the-box freezing came to me. I got a call the other day that, madam, I want to freeze my eggs. She's 27 years old and with PCOS. So I said, what, we can watch your AMH. It was 9.6. We can watch your AMH for every year. And if we see a drop, then we'll freeze it. She said, no, but I have heard in PCOS that you don't get good quality of eggs. So age related, I should get good quality. So I would like to freeze my eggs. Sorry about that. So if you look at my age is 27 right now, age-related quality will be very good. So I would not like to freeze. I would like to freeze my eggs now rather than at 34. So it's certainly thinking. So in certain type of patients, I think you have to take different individualization is very, very important for each patient. We all know cancer survival rates have really increased among children, adolescents, young adults. And that is why the need for fertility preservation, awareness, and counseling has grown in parallel. So these non-cancerous conditions, but we also have to think about cancer affecting our children and our young adults, and how today the treatment of cancer has really progressed, and we can give them a quality of life, and there is life after cancer, and that is why we must think of their future. Today I get a lot of patients who want to have babies and their ovarian reserve is completely gone because of the radiotoxicity, because of the chemotoxicity that has occurred in them. So I think today is the time to be aware and to advise them fertility preservation. So fertility preservation in cancer patients is something really a growing science, and I'm sure you've heard a lot of people talk about it. Of course, a lot of people are involved, the fertility preservation specialists like me, oncologists, and of course, counselors. And the approaches are different, depends age, cancer type, the type of treatment, presence of male factor. You can preserve what? You can preserve the eggs, you can preserve embryos if she has, and you can also preserve ovarian tissue. So today, these three are available to be preserved. So I think you should go about that for patients. So, and of course, when the counseling is done, you have to offer, but in our country. So, cryopreservation technologies are endorsed by the ASRM, and we are doing. So far, no one has yet come back for ovarian tissue transplantation, thawing and transplantation back. But these people will come back. So remember, when it's cancer, I always keep the chart in front of me. The risk of fertility depending on the gonadotoxic agent regimes. And remember this, if it's a high risk means, it means 80% chance of having amenorrhea. So the damage rate is very high. So high risk and intermediate risk are the patients where you should offer fertility preservation. Normally, if there's less than 20% chance of ovarian damage, you could tell them that they can take a chance. But I think, you know what, when if I am a patient, I would like to know whatever my risk is, whether it's very low risk or no risk, low risk, intermediate risk or high risk. And it should be a informed decision made by the patient and her family. So I think we as doctors should help them, guide them, give them pros and cons about freezing or not freezing. But at the same time, you should let them make an informed decision. Then radiotoxicity also, depending on the therapy dose which the ovary gets, the effects are noted here, and you should keep this in mind. So this is a chart I keep in my OPD for reference always. Then when I'm talking about ovarian tissue freezing, so when you're going to freeze ovarian tissue and transplant it back, you should know the risk of ovarian metastasis. Because if you transplant the tissue back, you should not give her back the cancer. So the ones with the lowest risk are the ones where OTT, ovarian tissue transplantation, can be done. Breast cancer, squamous cell carcinoma of the cervix, Hodgkin's lymphoma, osteogenic carcinoma, Wilms tumor, a non-genital rhabdomyosarcoma. Whereas leukemias, they're the highest risks. So I think when you're doing ovarian tissue freezing, these should be kept in mind. You must keep this in mind. But there are a lot of new things coming up. So you can offer these treatments to the patient. And maybe 10 years down the line, this tissue can be transplanted in differently. So this is a very easy and something that we should remember. That number of eggs per age to get at least one normal or euploid embryo. So younger than 35 is 4 eggs. 35 to 37 is 5 eggs. And as you age, if you go more than 42, 20 eggs are needed to give you one euploid oocyte. So, if you preserve eggs at a younger age, it's much, much better. The egg preservation procedure is very, very simple, actually. You do stimulation for 10 days, then you do egg retrieval under anesthesia. You do egg denudation after 2 hours of retrieving the eggs. Cryoprotectant is added and vitrification is done. After the eggs are vitrified, they're stored. But if you need to use them again, they should be thawed. And ICSI, we do it after 2 hours with poloscope and laser hatching. So it's a very simple stepwise process which is there, but requires a lot of skill. To date, we've frozen more than 6,000 eggs in our Bloom IVF Center at Leelavati. So what actually changed the whole, why did this become so popular only after 2006? Because vitrification came in. In vitrification, if you can see the blue line in my picture, the temperature drops from plus 37 degrees to minus 196 degrees centigrade at the rate of minus 25,000 degrees per minute. It's just a steep drop. Whereas in the slow freezing process, you can see the blue and the green graph, where it goes very slowly for oocytes and for embryos. And this actually, what happens is, because of this sudden drop, there is no ice crystal formations, as you can see, and this does not damage the egg, and the meiotic spindle remains intact. So this means that when you get 10 eggs and you freeze 10 eggs, on thawing you get 9 to 10 eggs back. The retrieval is as high as 98 to 99%. This paper of Anna Kober, which I was quoting before, 2% of all cryo-oocytes were endometriosis, 7.2% return rate, and key conclusions were, for the oncology, 2% of all cryo-oocytes for oncology, 7.2% return rate, and what she concluded was 10 to 15 eggs are needed in under 35 to get a live birth rate between 40 and 70%. So I think this is a very important landmark paper, which actually tells us that we must have that many eggs at least. So now if you look at the time available, to start the cancer therapy, if it's really urgent and you need to start immediately, just remove the ovary and freeze it. But if you have time to do oocyte freezing and the patient doesn't want to remove ovaries, then you can give GnRH agonist and protect that ovary. Or if it's radiotherapy, you can lift the ovary and lift it out of the pelvis. But say you have 2 weeks time, then you can do stimulation and remove, do oocyte freezing. If you have 3 weeks time, there's something called double stimulation. So in one menstrual cycle, we do the pickup twice. And it is based on the simple principle of Beerwald and Pearson. I think in 2013, where they actually said that they would change the whole physiology concept, that in one menstrual cycle, there are 2 to 3 waves of follicles which come. And that's why you can stimulate twice and get twice the number of eggs. So if you're in a hurry to get the number of eggs, and as I said before, 10 to 15 eggs is what is required in under 35. So if you get that time to do it. And there was something else which is very interesting in Anna Kober's paper also, that even if the patient had taken chemotherapy and after that they had frozen the eggs, it was still good enough to get eggs. So I think it's never too late for anybody, and you should offer it to your patients. So as I said, you can start anytime. Because of cancer, therapy cannot be, you cannot wait. You can start anytime during the treatment, early or mid follicular phase, late follicular phase, luteal phase also. sorry, ovarian tissue cryopreservation. I think this is a beautiful paper of 285 ovarian tissue transplantation, ovarian tissue thawed and transplantation done. And these participants were from France, Denmark, Germany, Switzerland, Spain, and Belgium. And 5 renowned teams did it. The ovarian function recovery lasted for several years, and live birth rate was 30% natural conception. And those that needed IVF were like poor responder live birth. Positive results was best in 5 years younger patients. You know, younger patients gives you better results. Age is very, very important factor. And as I said, patients after several cycles of chemotherapy also could benefit from ovarian tissue cryopreservation. So please remember that. So this is the ovary, and unfortunately the video is not working, but me and my son Rohan, we had gone to Claude Sanderson in Denmark, and it's a very interesting case. That's why I want to talk about it. That this girl was 25 years old. She had removed her one ovary and sent it because her mother had got premature menopause at 36 and her older sister had got at 34. So she was worried about getting premature menopause and she didn't want to have a child so early. So she had removed her ovary and sent it for freezing. So this is also something out of the box indication for ovarian tissue freezing. Is it superior to egg freezing, the ovarian tissue freezing? Actually, it gives natural HRT, it gives natural conception, as you saw in that paper by Dolmans. So yes, it could be, but it is an invasive procedure, so we have to think about it. So advisable to refrain ovarian tissue transplantation in survivors of leukemia, but for lymphoma, the auto transplantation is absolutely safe. In vitro technique, you can actually promote growth of immature oocytes contained within the stored tissue. As I've told you, you can do it by IVM, etc. And those leukemia patients if you want. But again, the success rate is not that great. And experimental fertility preservation techniques is xenotransplantation. You can transplant the ovarian tissue onto an animal and grow follicles and take it out from there, but it's still an experimental process. Then in vitro growth or artificial ovary, which Susan Pors has done, and she says her research is at least 10 years more to actually do it in humans. But Octay has used the decellularized human extracellular tissue matrix, because what happens is when you put this ovarian cortical tissue back, the angiogenesis takes about 10 to 14 days. In that, there is hypoxic damage. So when you use this DHCM, what happens is the vascularization is faster and the loss is much, much lesser of the follicles. So definitely Octay has shown better results and it is being used nowadays. The other thing that I want to say is in children. In children, ovarian tissue cryopreservation, oocyte cryopreservation, those who are of course pubertal, and ovarian transposition has been suggested. And there is an oncofertility prediction tool which has different parameters, AMH, agent exposure, type of cancer, etc., and age of the patient, which actually gives a predictive value and tells us to evaluate what it would like give an I think it's there are many, in fact, on it to get better results, and it is being used. So this is the chapter has got repeated. So I would like to end my talk by saying that life exists after cancer. Oocyte cryopreservation and ovarian tissue cryopreservation are no longer experimental, and oocyte cryopreservation should be liberally offered for social reasons and vigorous counseling. In fact, the ART law, which has come in now, has actually mentioned social reasons for freezing eggs. So it has become very official now. And remember, even as gynecologists, you get a lot of patients of endometriosis, of SLE, of different ovarian adnexal masses. genital tuberculosis, which actually require out-of-the-box thinking and advice from gynecologists about fertility preservation. So please do think about it and use this very advanced technology, which is freely available in our country to help our patients. Thank you. Thank you very much.
I think it was a wonderful update by Dr. Nandita, this thing, and very rightly said that life exists after cancer. But I see she pointed out the things which we see day in, day out, that is tuberculosis, endometriosis, where you can find that ovarian reserves definitely takes a nosedive initially only also. And she very clearly emphasized that, that whether an endometriotic girl comes in her 20s, that time also you must get an AMH done. And she should know from the very beginning that, her things can come down. In tuberculosis, we have seen that, tuberculosis is a bad disease and it definitely decreases ovarian reserve markedly. But when it comes to cancer now, because the survival rate is so good, fertility preservation is the key. And it is no more experimental. This is what I wish to say, that you can preserve your eggs, you can preserve your embryos, you can preserve your ovarian tissue. The only thing with ovarian tissue is that the technology has to seep into the distant to the gynecologist. But as far as egg preservation and embryo preservation is very much possible. But what it requires is a vigorous counseling that, with 1 or 2 eggs, you can't do anything. At the age of 40, you require something like 10 to 15 eggs, and by after 40, it's more than that. So I think, number of eggs which you preserve has to be also adequate. So for that, a vigorous counseling is required for such sessions. So I think with these remarks, I will say that, things were absolutely superb talk by Nandita, and I just wish to give her a very sincere greetings, that and warm wishes that, whatever she's aspiring in FIGO, she should definitely have her dreams come true. A person who has worked as a FOXY president had been very successful. I feel, it is, and if she wants to wish to represent the country, she should get her due. So with these remarks, again, my great wishes to you, Dr. Nandita.
Thank you so much. Thank you, Dr. Sharda Jain ma'am, and thank you for summing up this very important messages that Dr. Nandita has delivered through her talk. It was actually the need of, we should all start thinking about it. We should know about it as a general gynecologist, and as fertility specialists, we should also try to practice it in the cases that need it. So if Dr. Paiser is there, can we have Dr. Paiser's remarks? I think Dr. HD Pai hasn't joined us yet. So maybe we move on. Dr. Manish Banker sir has joined. Sir, actually we were waiting for you in the first talk that Dr. Seema had given a fantastic talk on mental health. Coming on to the very basic and I think a very simple panel discussion. Actually, once we framed it, we thought, why should we do it? Because it was so simple, improving the preconception health and talking something very, very basic on that. And but then we thought, no, but we've been talking complex things. We have mastered ovulation induction, we've mastered endometrium, but still we are not getting 100% results. So where are we lacking? And as Dr. Seema said, if we improve the mental health, we can improve our results twice. So maybe the preconceptional part of our health needs to be stressed, and we have stalwarts for that. They none of them need introduction actually today, that the panel that we have. And with this, in the panel moderation, I have Dr. Manju Daga with me. Thank you, Dr. Manju, for joining. Dr. Manju is a director at the Nestlings Fertility IVF, and she's ex-head of Department W Pratiksha Fertility IVF. And she is a ESHRE certified reproductive surgeon and has trained in Singapore and conducted many workshops. So thank you, Dr. Manju, for joining. As we go on, I'll quickly introduce our panelists for today. We have Dr. Next, please. Yeah, we have Dr. Paisa. Next, Dr. Jaydeep Tank. As Dr. Pai, I had already introduced. I'll just briefly introduce Dr. Jaydeep Tank, though. As I said, it is all of them need no introductions. Each and every one of us know them. Dr. Tang has been the Secretary General for FACILITATOR, and he has been immediate past president of the Mumbai Obs-Gynae Society, and it is a very, very busy CV slide, and actually it is my privilege to read it, but I will forego this because of scarcity of time. Welcome, Dr. Jaydeep, sir. Then we have Dr. Sharda Jain ma'am. Ma'am has been introduced. We have heard her, and we will be listening to her in the panel as well. And then we have Dr. Neeta Singh ma'am. Also, I have introduced ma'am in the past talk. Ma'am is the senior consultant professor at All India Institute of Medical Sciences. Then we have Dr. Banker. Also, I had introduced. He is medical director, Nova IVF, largest chains of IVF groups in India, awarded BC Roy, and he is a board member on many editorial boards. Welcome, sir. And Dr. Sonia Malik, ma'am, director, head of department, South End Fertility IVF, and she has been a past president in Indian Fertility Society, chair in Infertility Committee, FOGSI, past president, Indian Menopause Society, and associate editor, Southeast Asia Journal of Global Health. And ma'am actually is a thorough academician. Ma'am, so many students have, and so many centers South End centers that she has been running, and now with the Nova South End Fertility, many of our youngsters have been trained under her. Then we have Dr. Sudha Prasad Mam. Dr. Sudha Mam is presently the president of the prestigious Indian Fertility Society, director, Matritav Advanced IVF Training Center, New Delhi, has more than 34 years of teaching experience, has been the former professor IVF coordinator of the Reproductive Biology Center of the prestigious Maulana Azad Medical College, Delhi. She was also vice president FOGSI and president of AOGD, and many society member of Infertility Committee, Endometriosis Committee, and so on and so forth. And ma'am has received state award for her meritorious service in healthcare. Welcome, Sudha ma'am. And thank you so much for sparing time. I know you have another commitment here after this. And last but not the least, we have Brigadier Dr. R.K. Sharma, sir, who has been as a teacher to many infertility specialists in Delhi. He is the director of the Ma Institute of Reproductive Medicine Center, ex-director, head of department of the Reproductive IVF Center, Primer Super Specialty, and was also the founder director of the Army Hospital Delhi, Southern Command ART at Command Hospital Pune. And sir has been on advisory of many ART programs. Welcome, sirs, and thank you each one, all these senior dignitaries that are there for this panel. Actually, the panel is very basic, and I think can we stop sharing, Ankit, so that I can share my screen?
Yes, ma'am.
So why is it not coming? Can you see the screen? Okay.
Yes,
yeah, now it's okay, no? So this is the panel on improving the preconception health to maximize the IVF success. And I request Dr. Manju to please start the panel. So we have these components of preconception care. We have these medical conditions that we would be talking on, the various medical conditions, the stress, and other, sorry, I went back. The nutritional issues, the psychosocial issues, the immunizations, the various infections, the genetic screening, and the psychological counseling that we would be talking to our experts here. So, Dr. Manju, can we start with the first question?
Hello, Dr. Jyoti. Thank you so much. And good evening to all my seniors, all panelists, and all participants. Let's start the panel discussion. So obesity nowadays is a major problem in India. So let's start with the obesity only first. Like we have a one problem, like one patient, woman of 34-year-old, and her BMI is 27, and she approaches to an IVF center to start an IVF. So does obesity affect IVF? Do we go straight away towards IVF, or we advise patient to lose some weight, and any effect of the weight on women fertility? So this question, Dr. Sharda ma'am.
I think, you have, you're talking as far as the weight is concerned, I think it's very, very important. And as far as we Indians and Asians are concerned, in the BMI scale, which is accepted globally, for us, it has to be minus 2.5. So obesity is, if it is 30 BMI for the rest of the world, for us, it is 27. So this lady who's already 34 years old should know that the BMI itself is an intermediate indication that her time for a conception will be 3 times more than in comparison to the people who had a normal BMI. So I think this she should know at the outset. And if she knows that if she decreases her weight by 5 to 10%, a whole lot of whether it's pregnancy on its own, or little help of the ART procedure, she can have very readily conception. Because as we all know that all these patients have not only they have comorbidity like diabetes, hypertension, dyslipidemia, but they also have menstrual problems, and they take a lot of time in conception. That particular part should be very, very clear to these people. So she need to normalize her weight. And as far as she's already 34, and as we all know, that Indian people have poor ovarian reserve in comparison to their Western counterparts 5 years earlier. So she should definitely have all workup done beside other investigations on the ovarian reserve as well. So this is my take thing, that she need to normalize herself.
Ma'am, there are day-to-day practice. Yes, we advise, we counsel the patient, just you lose weight, your chances of conception will improve, complication in pregnancy will goes down, and your cost of the cycle goes down because the injection cost is low. But still many patients we advise for weight reduction, and when we see after 2-3 months, they are at the same weight.
When I talk about this, I always talk that they must go for a weight loss in dedicated weight loss clinic. Because unless they go in a dedicated weight loss clinic, the clinic itself is going to work hard on her, and she will see to it that a 5% or minimum weight reduction is not difficult at all. 5% is 5 kg. Yes, so which to my mind is not difficult at all.
So for all these patients, we should arrange a weight reduction program. We include dietitian, we include an exercise and yoga program, and we guide and counsel.
Most of the IVF centers have associated with that.
Yes, ma'am. Yes, ma'am. Thank you, ma'am. So very nicely summarized by ma'am. So the next question is this: a woman of 37-year-old, ma'am, and the BMI is 30, her AMH is very low, 0.9, and now she approaches for IVF. So how we guide her, because we know the impact of obesity on conception, on fertility in pregnancy, morbidity and all. But now her AMH is 0.9, her age is 37. So how much we wait to start this IVF program? or we can directly go ahead with this.
BMI is 30 already, you know. So
Yeah.
I find, you know, by the time we are going to work on her, because AMH is, you know, just the cutoff, you know, she's already losing time. So what my suggestion will be is that, you know, even if she goes for, you know, program for IVF for herself, she should be told that 5 kg weight loss, I think, you know, in a matter of 2 months, she should definitely get it done. And this is the time that you tell her about the diet and other things. She exercises, she works on her lifestyles and things like that. But she need to know that everything is in borderline. And as far as the effect on her ovum quality is also affected quite a bit. A whole lot of things get affected about it. They have less eggs. Already her reserve is less. So the legs will be there. There'll be less embryos will be there of a good quality. And she will have less embryos for transfer also. So everything she need to be counseled in detail right in the beginning. And if his partner is also, if the similar weight, then, you know, she should be equally counseled as far as the male partner is concerned. So I think, you know, a vigorous counseling is required in such patients, and vigorous action is also required in such patients. And I will definitely say, you must find out what is the underlying cause for her obesity, whether it is a PCOD or whether it is any other thing, you know, that also things that need to be worked out. Definitely, she has a very less time to adhere, but the action will probably bring results.
Yeah,
But we can wait for 2-3 cycles just to advise and counsel her to reduce weight, and then we can start the program.
1.5 to 2 months, that time, ये कभी नहीं होता कि patient आया और हमने कल से IVF शुरू कर दिया. So workup also requires both at the husband side and at her side.
Yeah, would you like to add anything, Sonia ma'am? How it is affecting the IVF part, and in these, as Dr. Sharda ma'am said, in the cases with low MH, what would you like to do? I mean, would you like to, how much rush would you make into that program of IVF in this case?
Very well. She summed it up very well. I mean, yes, there is an urgency because of her age, you know, and her AMH. But then, having said that, the obesity part is also going to deter us to a large. It's a out of the frying pan into the fire kind of a situation. Both sides, you know, we are. So I think the best thing to get out of it is counseling, as Madam has said, to counsel her very well, and both the partners very well, in order to, you know, see that she understands what she's getting into. So, but with whatever we have, we will have to, like Madam said, not waste too much time. Try to do as much as possible, as much of weight reduction as she can during the time while we are working her up. Don't give her that extra time that we are thinking for other people, but in her case, just that much. And basically, you know, there is a difference between a PCO obese and a non-PCO obese. A non-PCO obese, you know, there are no definite guidelines that antagonist is going to work better or this much dose is going to work better. We don't have definite guidelines for a non-PCO obese patient. And they unfortunately, you know, don't follow any trend. They don't sort of, when we are giving them gonadotropins, they may produce eggs, but they may not produce eggs, you know. So you have both kinds of patients over there. And so it is difficult in such patients to actually to yourself also understand what kind of a stimulation pattern they are going to follow. So that, of course, has to be kept in mind, and we have to tell them all that.
Any difference in the oocyte quality, ma'am, or the oocyte?
Yes, of course. Of course, there is a difference in the oocyte quality. But again, like I said, every patient who is obese may not behave the same way. There may be certain patients where you may be able to get away with some good eggs and good embryos as well. I think Brig Sharma will give you a very good insight into the granulosa cells also of these cells, because he's a very acute embryologist and he looks into every cell very, very minutely to understand what is the basic problem. So I think you should be asking him this question.
So how do you, in those oocytes, in obese, do you find any difference in the number, in the quality, in the embryo that is formed, the gonadotropins that are used? Your comments, sir? As an embryologist, how do you feel?
Firstly, you know, these Indian obese patients, when you see, they have a abdominal, you know, fat much more than on the other side. So when we are giving them the gonadotropins, we should not give it subcutaneously in the abdomen, because
Correct.
it takes a lot
It's
of
not
time
going to
for
be
that
absorbed.
gonadotropin to reach. So the dose required will be much more. So you give me on the thinner part of the body, like thigh or the the forearm, where the fat is less, so that the gonadotropins can reach the ovary better. And what the gonadotropins, if we have a spikes, they give better result rather than a slow release from the fat. So you should try to select a place of giving the gonadotropins which is less fatty in this obese patients. One thing. Secondly, these obese patients, because of possibly many factors are working in them, and you find that the quality of the oocyte and the the granulosa cells which are coming, the cumulus cells which are coming with that, they are different than what we see in a normal normal weight woman of the same age, for that matter. Now how does that the changes now because of the this hormone genesis in these patients? You find that the zona may be thicker, or it may be little abnormal shape, and also you will find that the granulosa cells, the cumulus cells which are attached with them, are lesser in number. So you'll find very few granulosa cells or the cumulus cells around that. While in other patients of the same age, you may find that the volume of the cumulus cells are more. So because of that, you find that the quality of the embryos also is less in these obese patients in comparison to the thin patients of the
Okay, so
same
that
age.
is something very unique that you have told us. And also one very important thing that you brought out was that we have to use a thinner, I mean, so that the quantity of gonadotropin used is lesser. Otherwise, the studies always say that in obese you require a more dosage. So, so this is something new that we have learned from you today. That
And two things are there. If when you're giving a trigger, you should
Trigger
never
also,
give
yes.
subcutaneously. It should be always
Correct.
intramuscular. And secondly, we must always remember that the endometrial receptivity is also affected quite a bit.
yes, ma'am. So, and what about male infertility? Again, Brigadier Sharma sir, obesity and male infertility. What is the relation? Whether even we have to force the husband also to go on the treadmill along with the wife as well. So,
Yeah. See
yeah.
what happens in the obese males. If you do the testosterone estrogen level, you
It
find
is
that
still
the
less.
ratio is affected. They have more estrogens in the body, and which affects spermatogenesis. And secondly, because of the high estrogen, their libido is also less. So with the result, they have a less frequency of intercourse. The natural chances are also less. So whenever you find there is a poor seminology in these patients, then it is advisable that they should also reduce the weight, so that the quality, the quantity, and the morphology of the sperms will improve in these obese patients. And otherwise, these patients are also given letrozole for a long duration to improve on the seminology.
I think the male obese patient was more problem because not only they have a mechanical sexual problems, but they at times have quite a significant number have erectile dysfunction as well,
Yes,
beside
yes.
the poor semen quality.
Correct.
Right, ma'am. Right.
More of libido problem.
Yeah. So not only impaired semen quality, they have sexual dysfunction, endocrinopathy, psychological issues, sleep apneas, and epididymitis, inflammatory, obstructive elements added to that. So there are many issues, even not only female obesity, it is also the male obesity also which we should take care of. Dr. Manju, over to you. I think Dr. Manju, are you there?
Is there?
Okay. Dr. Manju, okay, I think
So there is one more patient, is male. Yeah, yeah.
Okay, yeah, continue, please.
Now, more situation in male obesity is healthy obese male with BMI parameters approaches for advanced pump testing, or we can advise weight reduction and wait for that. So what is your say, sir? Brigadier Sharma, sir.
Yeah, the thing is we have to give a composite treatment. We
Yes,
can't, compartmentalize. So we have to do the semenology and we do the DNA fragmentation test also for these patients, and also advise them to reduce the weight as well. And then you give them sort of incentives for increase in the reducing the weight by checking the weight in your lab or in your clinic regularly whenever they come to you. So when the patient comes for the review, so okay, oh, good, congratulations, you have lost half a kilo. That gives them the more confidence to reduce the weight. And secondly, the DNA fragmentation, it's a more of a objective things to show to the person. Your DNA fragmentation is 50%. Now, if we have this high DNA fragmentation, your success rate will be less. So that will be another incentive for him to improve his weight, so that he knows, okay, my DNA fragmentation is now becoming better and better with time. So, it encourages him to lose more weight. So I think every consultation with these patients and fertility is an opportunity for us to help them improve socially, emotionally, physically, and spiritually.
So take home message in this is obese male, even despite of the normal sperm parameter, we should do advanced testing. We aggressive counsel her and we advise her to reduce weight and take in the weight reduction program before we go ahead with that. Thank you, sir.
And the cigarette smoking and alcohol, and they must be told very clearly, if you want to have a child, both you have to give up.
Yes, ma'am.
This is my next question. Okay. That was
next
healthy obese male, ma'am. No diabetic, only little cholesterol level, lipids are a little deranged, normal sperm parameters, just BMI is 32 and want an IVF. So what when we go ahead for IVF, whether we advise him to reduce weight, whether we go ahead with the advanced semen testing, or we go ahead directly with IVF.
As Dr. Brigadier Sharma has said, that these patients in the workup should definitely include the DNA fragmentation test. And then once you find that all these patients will definitely 50% will have a DNA fragmentation test abnormality, then they become serious about it. And I think 32 BMI is too much of BMI for Indian male.
Yeah.
And whole lot of comorbidities, they are not there at this particular time, but they must be told their semen quality definitely gets affected. And when they have a lot of, this central obesity, it definitely affects in one way or the other, all the semen parameters, all the quality of things of the sperms. And I'm sure this hyperlipidemia, which you had just said, कि थोड़ा सा कुछ नहीं है तो थोड़ा सा cholesterol and dyslipidemia, but I think that brings some major problems in her. So reduce the karna hi padega weight usko.
Yes, ma'am.
Okay, so coming on next, again, we come over to our next question here. We have a couple coming in for IVF at the age of 34. The lady's age is 34. The male is 37. Her AMH is 1.2. Husband has asthenozoospermia. Both are chain smokers, around 10 to 15 cigarettes a day. Both are alcoholic on weekend boozing. And does the smoke and alcohol affect IVF, and how we counsel? So I would take smoking part with Dr. Jaydeep sir, and alcohol part if Dr. Sudha Mam can can introduce to us. Dr. Jaydeep sir, about alcohol, about the smoking part, how it affects the male infertility and the female infertility, and how we start counseling the couple on that.
Thank you, Jyoti, for inviting me for this webinar. I hope I am audible.
Yes, sir. Yes.
Yeah. And thank you, Dr. Manju, also for co-moderating this. I must say it's a pleasure to be among such illustrious company. Dr. Sharda Jain, Madam, of course, Rishikesh, Dr. Sudha Prasad, Dr. Neeta Singh, Manish Bhai, Dr. Sonia Malik, and Dr. R.K. Sharma. And Seema and Nandita must be congratulated for such a wonderful talk. You actually given me the easy part of the question, because there is excellent evidence to show that smoking does affect fertility both in males as well as females. And as a general health measure, it is of course advisable if a couple who is smoking 10 to 15 cigarettes a day is either asked to cut down or refrain completely. But I must say that this is easier said than done. like any addiction, I wouldn't say that having a couple of drinks on every weekend is an addiction, but 10 to 15 cigarettes a day is certainly an addiction. And that might actually be much more difficult for the couple to either reduce or give up rather than the drinking part. So on the one hand, you've given me an easy question because smoking clearly affects fertility and cessation of smoking clearly improves fertility. But on the other hand, practically speaking, it's not really that easy for a couple to give up smoking. It requires a fair amount of willpower. And I think a lot of mental support, something which Seema alluded to in her talk, a lot of counseling and support, etc., would be required. Having said that, I think when you ask a couple to give up smoking, the question then would arise is whether you would allow them to use nicotine patches or not when they are conceiving, because that apparently nicotine patches or the nicotine chewing gum are two of the ways you wean off smokers from this thing. But I would actually think that it might be a good idea for them to just go cold turkey rather than try to reduce cigarette smoking or use the patch or the gum, because nicotine in any amount will actually mean that they are more susceptible to restart smoking. So I'll hand over to Dr. Sudha Prasad to answer the more difficult question.
Yeah.
Thank you.
Yes. Yes.
Thank you, Jyoti. I know any addiction when the infertile couple has, whether it is with the male or the female partner, it becomes very, very difficult to absolutely say straightforward that you stop it, then only chances of pregnancy are there. It's very, very difficult. So it requires a vigorous counseling. Very well, you have to counsel, and slowly and gradually you just build up that, see, this all problem can happen. Once in a while smoking, small ounces may not be any effect, but if they are the complete everyday smoking and the alcohol, if they are having, then definitely it will reduce the condition of their oocyte, their fertilization, their embryo quality, and definitely it will be there. So lifestyle improvement rather must be there, and it has to be counseled properly. But one should not say that go and deplete your all intake and then only you come back for the IVF. It is not. As in the same kind, I was hearing about the obesity. We cannot say it's very, very easy to put on weight rather to decrease the weight. It's very, very difficult. I had a very good project from ICMR for the obesity and the IVF patients and the yoga sessions. So mind, body, yoga, we have done together, and we found that definitely the yoga gives very good result if 40 times patient has done before starting this ovarian stimulation. Similarly, for the alcohol and the smoking, in a government hospital, we used to get bidi smokers, you know, and the alcohol, something like a local one. So we have counseled, we have counseled them that, see, once in a while, start decreasing your ounces. You just give first, not daily, alternate day, then third day, then seventh day, then probably, yes, you will decrease. Chances are better. And after that, whatever you want, you can do. But during the conception time, when we are going to start the investigation, and even the FSH endocrinal level also, you know, changes. So this is very much important to make them understand. It is very, very difficult, I must say, if they are having the good addiction, but definitely it will require the very good counseling, and you should be, doctors are a very good counselor. So you should have less number of patients and you treat it properly. That is the message should be there.
What about caffeine, Jaydeep sir? Caffeine, how many coffee cups, tea? Patients ask whether they can take tea and all. So what is the role? How does tea affect fertility, and caffeine, what dose, how much, and other recreational drugs, substance abuse? How should we counsel our patients?
It's quite easy to say no to things, isn't it? As long as you're not the one who's quitting it. But so it's quite easy to tell patients don't do this and don't do that, but not really as easy for the patient to follow in practice. Recreational drugs obviously are a strict no-no, including what are known as gateway drugs or soft drugs like marijuana, etc. are a strict no-no, really, and there is no question at all. And there is, again, excellent evidence to show that drugs like cocaine or something of that sort actually have significant detrimental effects on the fetus. So absolutely no question of allowing any recreational drugs, or if they ask you, in fact, it's a good idea to tell them, don't ask me again, otherwise I'll tell the police. Caffeine is another thing altogether. Caffeine is so much a part of our lives. Even our Prime Minister says chai pe charcha. I'm not really sure
how many
of
cups
how
of tea
you can
but
tell
allowed?
a
How many
patient.
cups can they have, sir?
I really have no thoughts on that, very frankly. Okay. It's very difficult to say that if you take 2 cups rather than no cups, or if you take 6 cups, your chances of pregnancy are that much lower. I really have no evidence, or I have no evidentiary basis to say take these many number of cups. I could say that if you are able to shift to green tea or an alternate, it's fine. But just because you're having 3 or 4 cups of tea or coffee a day doesn't mean that you will either have a detrimental effect on the fetus, or you will have lower chances of pregnancy. I would really be afraid of saying that to a patient.
Dr. Sonia, ma'am, you've raised your hand.
Yes, I have raised my hand because there's a very common question that girls ask in the cities. Can I have a glass of wine? They generally want to have wine on weekends, or even when they are pregnant, they want to have wine. So, all of us would immediately say, yes, you are not supposed to have it. But then there was actually, when I was screening the literature for what were these questions that you have put up, Jyoti, I was looking at wine particularly because this is a very common question that these girls ask. So there was a study in human reproduction way back in 2003, where they had taken up, they have studied 30,000 people from the Danish registry. And they have found that there is an 80% success rate if they are drinking wine. That the fertility is in fact enhanced by drinking wine. So basically, I think it's because of the contents and because of the antioxidants and the resveratrol or whatever it has. Maybe that may be a little more effective than the rest of the alcohol that we have. So I just wanted to share it as a part of an anecdotal report, I would say.
Red wine is allowed.
I know Dr. Sudha Prasad has her hand raised, but yeah. I'm just going to butt in here, and I completely agree with Dr. Sonia Malik. In fact, on the one hand, if we say that stress is a very important factor in reducing fertility, and on the other hand, the patient feels a little relaxed after a glass or 2 of wine, I think at the end of the day, you are not sure when she'll become pregnant.
Exactly.
And how long can you deprive her of simple pleasures of life? I'm going to say simple because I assume she's not drinking very expensive wine. But I really would not. I mean, of course, once they are pregnant or even in the luteal phase, I will caution them that it's not a good idea to have any alcohol whatsoever. But in the initial part of the cycle, I really saw no reason why we should not allow them alcohol in moderation. Moderation being the key part, of course.
So interestingly, the study
as about the caffeine is concerned, caffeine is concerned, I think we need to advise them that instead of taking a cup full of coffee, they can have a half cup. So that will make difference.
Yes, madam.
Yes, but yes, I will tell you, there are the research done. The 300 milligram per day caffeine plus no caffeine has been also compared, and they have found there was no relation. Means fertility was not affected.
Exactly, madam. Thank you for saying that.
Stress is relieved, like Dr. Jaydeep said, if stress is relieved by the simple one glass of wine, and probably with the sip of caffeine will also give the same kind of relieving of stress. And slowly, gradually, you do the counseling, and probably you can relieve her also.
But I think they must be given a word of caution, and if the caution is given, then they will definitely decrease some amount. You know,
Yeah.
instead of full cup, half cup, and then a frequency of wine intake also will probably become less.
But
And,
if you see in this study, they compared the intake of beer with wine. And actually they found that with beer, the fertility rate doesn't go up. I mean, it is, so we just cannot say that it is the stress which is relieved and gives rise to better fertility. It probably has something to do with the wine.
with the
So
wine
anyway.
antioxidants,
Great
in the
idea.
wine or something.
Anyway.
Brigadier Sharma, sir, you wanted to add anything? You had raised
That is
your hand.
absolutely against.
The thing is, as Dr. Jaydeep said, you know, it's very easy to say, patient, okay, stop this, stop that. But if we tell them why to stop it, it is not only going to affect the, you know, the success rate, it is also likely to affect the baby. Now, once they know that, oh, my baby is going to be affected, so that has got a more incentive for them to at least reduce whatever they are doing. So when we are counseling to them, we should not talk only about the IVF and its outcome. We should also talk about the, you know, the effect of alcohol, effect of smoking, and effect of these party drugs on the baby, chances of congenital anomalies and all. So that gives them bigger incentive for them to either stop it or go into moderation.
Jyoti, if I may, you know, I have always been, I'm sorry, am I taking too much time? Or
No,
can
no,
I
sir. No, please continue,
Okay.
sir. I'm just
Okay.
getting on to the
yeah.
next question.
I just want to say this, that when you counsel couples, particularly infertile couples and all pregnant women, and say that do this, that's good for your baby, I think that's actually a very fine line that you have to walk.
Yeah.
You don't want to stigmatize something and add pressure to the pregnant woman. And then, you know, when there is a poor outcome, you don't want her to feel, oh, I did that, that's why my baby suffered. So I would say that, you know, while I agree completely with what Dr. Sharma said, I would say that counseling is a fine art when you want to talk about the consequences of anything on the baby of a infertile or a pregnant woman. And the tendency to say that if you do this, your baby will do well, or if you don't do this, your baby will not do well, is something that needs to be tempered with a lot of caution. You don't want the couple or the pregnant lady to start feeling guilty कि मैंने ऐसे किया, इसकी वजह से ये तकलीफ होगी. अदरवाइज उसका 10th स्टैंडर्ड रिजल्ट में जब भी 70% आएगा 80% के बदले, तो वो याद करेगी कि डॉक्टर ने कहा था कॉफी नहीं पीना, इसलिए मेरे बच्चे को 10% कम मिले. So, you know, just a word of caution.
Right. Dr. Manju?
One more question here. So a couple is approached to the clinic, like husband has addicted to that cough syrup Corex, taking daily around 4 to 5 bottles, and wife is asking what is the permissible limit and how can we go ahead with this, because he is not ready to quit.
I think he should switch to wine.
Yeah, switch to wine. Red wine.
Okay. So
No, I think
Corex?
Manish Bhai had raised his hand. Manish Bhai, you raised your hand and then you
Manish
lowered
has
it.
raised his
I
hand.
think I see this whole issue of lifestyle and addiction is such a tricky situation. I think while in an ideal world, we would like all our patients to follow the healthiest of healthy lifestyle. If we put our hand on our heart, how many of us are able to follow it ourselves?
Yes, absolutely.
Having said that, when they come to us, they have been already pressurized, stigmatized by their family members and everyone. And now we also echo the same sentiment. Many times all we do is increase their level of stress, make them more dejected, make them more depressed. So as Jaydeep said, it's a very, very thin line. On the one side, we want to encourage them to have treatment. On the other side, we want also to have things in moderation. And from all our personal experiences, we know that all of these patients know what they are supposed to do. They're all educated. They've all Googled everything. If they were to do it, they would have done it before coming to us. So I really don't know how much of one more advice to follow a healthy lifestyle is going to practically work. Not that we should not do it, but from a purely practical point of view, how many of our patients would start following it from the next day? Extremely difficult.
Difficult, very, very difficult.
So the only thing is that let us not stigmatize them more than what they already are. I mean, tell them in a very, very polite way then it is up to them to understand. And some patients are very astute. Even if you tell them one, they will make that change tomorrow.
Right. So coming on to the endocrine part, sir, Banker sir, I think you can continue, since we all understand that as clinicians, that we have to have our thyroid levels within limit, that diabetes under control, the hypertension taken care of. Now, if this lady with a TSH of 8, HbA1c 6.5, a normal AMH levels within normal limits, husband sperm also normal. So what advice would you give her? What would be the level of TSH you would like to target, and HbA1c you would like to reach before you start with her treatment?
So I think these are thyroid, diabetes, and blood pressure are medical disorders which definitely need to be controlled, purely even from a medical legal compliance, because these have been directly linked to not only fetal but even maternal health. So given that she has a normal AMH, she's only 34, we need to give her proper time to get everything corrected. So advise to visit a good physician, bring her HbA1c closer to 6, TSH below 4 at least, and then I would start and her blood pressure under control.
Right. So
bringing it to 2.5 and 4 is a challenge. I think you cannot titrate the doses so well. So lower than 4 is fine. I think bringing it from 4 to 2.5 or 3 is a real challenge.
So those are the reachable goals that we can achieve, and not so tight, watertight controls that to start with. So because even we are losing time, she is already 34, I suppose, that we had put her age. So we have to have achievable goals, I suppose. That is what Dr. Banker wanted to stress upon, and that obviously we all understand that the thyroid and the sugar levels and the blood pressure and everything means we have to take care of her health as a whole, and then start with her IVF treatment. Over to Dr. Manju for the next question. I hope you have there. Otherwise, I'll share my screen. So we come on to the environmental factors for now.
Yeah. So Dr. Neeta, is she there?
Yeah.
So Dr. Neeta, there is a direct question: how the environmental factors are considered before conception? How they impact the our fertility part? What effect they have on the conception, IVF, and on pregnancy? Dr. Neeta.
I'm just unmuting.
Yes,
so I just want to show you some evidence-based slides. So we're talking about environmental toxins. So they play havoc on fertility. They cause significant cause of progressive loss of fertility, increasing body loads of environmental toxins in both men and women. Environmental toxins cause infertility in 4 basic ways. They are endocrine disruptors. So they lead to a different kind of endocrine imbalances in the body. They damage the female reproductive system. They damage to the male reproductive system and also impair fetal viability. So they not only influence the reproductive system, they're also endocrine disruptors. The second way, the key endocrine disruptor, which is impairing the fertility, is loss of blood sugar control. So the environmental toxin leads to endocrine disruption, leading to diabetes. It also manifests as metabolic syndrome like PCOS. You will find obesity. And the source of diabetogens, a lot of environmental toxins which lead to endocrine disruption are arsenic. 13 million people in US use public water exceeding Environmental Protection Agency limit of 10 microgram per liter. The organochlorine pesticides. So we know that not only drinking water is contaminated, but also our vegetables have loads of pesticides. And we have no standards of measuring, even in United States, where the vegetable seller is asked, they have to write when the vegetable was purchased, and they have to label it that this is free from pesticides. In India, we don't have such rigorous control. Second, very much important environmental toxin is bisphenol. So bisphenols is a very important content of plastics, and the plastic makes a very, it becomes an integral part of our life. So our water bottles, to many of our, eating plates are made of plastics, and they all have bisphenols. And you can see that the level of bisphenol, if it is high, it leads to tremendous endocrine disruption and the fertility alteration. Second important endocrine environmental toxin is dioxins, which is a byproduct of several industrial process. And higher the level of bisphenols, and the lower it comes in the from the body. Now, third very important environmental toxin we are worried about is polychlorinated biphenyls, and very difficult to break down in the environment as well as in the living organism, because it gets accumulated. And how does it come to our body? Is that despite most polycarbonated bisphenyls and dichloro, diphenyl trichloroethane, this is DDT, having been banned since late 1970s, but the BCPs are present and they get accumulated in the living organism like human beings. Now, environmental toxins directly control the fertility, and the chemicals which cause infertility are hexachlorocyclohexane, polychlorinated bisphenyls, dichloro, diphenyl trichloroethane, and as they increase, the fertility goes down. Women with highest level of PCB, there is 50% decrease in the ability to getting pregnant and much more likely to have a miscarriage as compared to the other. Now, environmental toxins which cause decreased fertility, how do they come? Our drinking water is mostly chlorinated water. So many of us have seen that, we decontaminate our water by putting chlorine tablets. And the drinking chlorinated water increases risk of stillbirths, more likely to deliver a child with small birth weight. Men in highest quartile of consumption of high pesticide residue in fruits and vegetables, that is the more than 1.5 servings per day, and there is 49% lower total sperm count and lower percentage of morphologically normal sperms compared to the men in the lowest quartile of intake of less than 1.5 servings per day. Now, the third very important environmental toxin is heavy metals. Infertile couple having significantly higher blood levels of mercury than the fertile control. So this is again a very important environmental toxin we need to take care of. Infertility has direct association with blood cadmium levels in women, then the blood lead levels in the men. In women, the blood lead levels are more than 5. The supposedly safe range is less than 1.5. And when it is more, it doubles the risk of preterm delivery and increase in spontaneous abortions. And the last environmental toxin or pollutants which we all face in every winter is like, the smoke. So women smoking more than 10 cigarettes daily, as we were discussing, it reduces fertility. When Ireland banned smoking in the working place, the rates of preterm birth reduced by 25%. So because all of them were passive smokers, and at the workplace, the smoking was banned. And the air pollutants that have biggest impact on fertility, that is PM10 and the total suspended particles of the sulfur dioxide, carbon monoxide, and nitrous oxide. And who can know better than us who are living in Delhi that what happens to every year in winters when we have such high level of air pollutants. So air pollution and female fertility, there was a systematic review which was published, and they found that in this meta-analysis, they included 11 articles, and in IVF population, they found that there was a decrease in success rate. And if there was high particulate matter, then miscarriage rates were found to be increased. The influence of direct, then the third indirect environmental pollutant is the mobile phone radiation, because it has a direct influence on the sperm quality. So this is also a very beautiful paper which is published in Andrology, and in which they have shown that they selected 32 healthy men with normal semen parameters, and they recruited in the study, and what they concluded that in these men, they had exposure of 5 hours in a thermostat, and what they found was the number of non-progressive movement of spermatozoa was directly linked higher in the group which was influenced by cell phone radiation. So this there are not many published articles about the effect of cell phone and the mobile phone radiation on the male fertility. I found a very good paper, so I thought I'll share. So they not only increases the DNA fragmentation, was also found to be significantly higher in this group where the mobile phone usage was high. So these were some of the very important endocrine disruptors and the environmental toxins which are playing havoc in the fertility and the fertility.
Absolutely, ma'am. You covered each and every part of the environment. What do you say about laptop usage and in male infertility?
Very much. So the use of mobile phones, I did found the use of laptop actually. I haven't found much studies talking about the use of laptop. But they say that if you really use the laptop on the labs and the men are using for a long time, then because of the heat of the laptops, they have found that they reported some fertility in men. But they found the prolonged usage like 5 to 7 hours keeping the laptop in the labs. So we recommend that laptops, although it is meant to be kept in lab, but infertile men should keep it little away on the table or not really on the lap. Yes.
Yeah. So thank you so much, ma'am. And as an afterthought, I'm just thinking that during lockdown, the fertility rates increased. I mean, many of the couples started conceiving on their own who were in the infertility queue, waiting for IVFs and all that. So one was that cohabitation, and they could spend time, the tension was less, stress was less. And secondly, maybe the pollution was less. So
and the third thing, they had nothing else to do.
Yeah, but
no conferences, no movement, no travel, and they have to be inside the house. So whatever time they were there, they were spending with each other. So I think this was also a reason that the
but work from home means more laptop usage on the lab. So that is another dangerous thing. So people should be using tabletops.
Yes, not the laptops.
So that is one thing. So thank you so much, ma'am. Coming on to the nutrition part, we come on to Brigadier Sharma, sir, and Dr. Sudha, ma'am, if you could add something on nutrition. We have PCO diets, we have Mediterranean diets and whatnot. And what is this plate concept of how much food should be there, how much protein and all that. So if you could just give a brief info onto that, macronutrients and all that, sir. The healthy eating plate. So this is a plate model of a balanced, healthy diet. But I would, from your own experience, what do you suggest to your patients?
In India, what we see, we have two extremes. One is the patients who are having very poor nutrition, and on the other hand, we have obese patients. So we have to categorize the patients accordingly and then advise them about the nutrition. Now we have to tell them what is the healthy nutrition that will contain both macro and micro nutrition. So macro nutrition is carbohydrates, proteins, and fat. How much they should be taking it. So there's a plate model, what they call it. So 1/4 of the plate is carbohydrates, and 1/4 of the plate is the protein, and half the plate is of vegetables. So that is like our good Indian, diet. So and on top of that, they say one should take extra fruits along with that. Now the thing is, in the proteins, what type of proteins we have to advise them. So it's better to take the lean white, meat rather than having a red meat, more of that. And also better to take, processed meats rather than the processed meats, which is available to them. And about the micronutrients, the folic acid and the iron, because many of patients may be anemic also. So we have to guide them accordingly about that also. And the iodine levels, because now with this iodized salt, coming in vogue, most of the patients would be using that. But then, some patients may have iodine deficiency also, which may manifest as a goiter, and also we have to see the thyroid function and look at the thyroid and then treat them accordingly. So a well-balanced diet, which includes carbohydrates, which includes more of vegetables, and carbohydrates also, the low glycemic index carbohydrates should be advised. The maida and all should be avoided, and they should take whole grains, or mixed grain carbohydrates. So, and then, this is also applicable to the male as well, not only the female, because many of the males, they if they're working, they'll be missing the meals in between. So that also has to be told to them. The frequency of the meal should be, maintained. Otherwise, what happens? They eat in spurts, or binge eating is there. Suddenly they will eat, high nutritious diet, and then for 12 hours they have not eaten anything, and that would, cause the insulin issues with them. So that also one has to talk to them, not only the type of nutrition, the type of macro, micronutrition, and also the timing of the, the food intake should also be told to them. And regarding, giving the supplements, if it is required, if you find that the patient, requires some antioxidants, or if the sperms are the motility is less, or morphology, then maybe you may add, selenium and other micronutrients to them in various forms which are available to help them to improve their immunology.
I think Dr. Sharma has given a very vast, wide view about the nutrition, which is absolutely required. We have discussed about obesity, we have discussed about the anemia. So naturally, we don't want to recommend the fatty, more of fat, more of carbohydrate, high protein diet is must. And this should be basically, it should be a balanced diet, that which is special diet for the infertile woman. We should not try to make that, ye iska khana hai, so she's a patient, she has to have. And finally, the whole of the family member will say that, see, I have given you the special diet for months together and still no pregnancy. So this kind of increase the stigma. So it should be a balanced nutritional diet. We should have a good protein, the greeny leafy vegetables should be there, and they should have a regular, there should not be fasting. I had a Thai patient, the female used to, 3 times she used to keep fast, and she was hardly 45 kg. BMI was so poor. Even those BMI also, it's very, very difficult. Anovulation occurs, and even though you give the gonadotropin, the quality of oocytes are not good. So many things are there, not with the obesity, with the decreased weight also, the same kind of problem can happen. So we should say, and I have heard now, I do not know how much is there, that if people eat, infertile couple, female have akhrot, apricot, then probably they have more fertility. I do not know how the quality increases, but probably it contains more of antioxidant. This may be the additional thing which the female will have only, and probably it will have the better quality of eggs. This may be the possibility, but definitely a balanced diet is must.
Jaydeep sir, when the patient comes to you, what all supplements you start them with? Folic acid is okay. Any other thing you think of? Vitamin D and multivitamins, vitamin B12, iron, anything you feel you should like pump into her before, I mean, because she has been deficient or something, or you don't want to overburden them?
I don't think it's a question of burden. I think it's a question of need. And if she needs a given supplement, you should give it. But I'm not really sure of the need of giving it to them empirically. Folic acid, of course, has a definite purpose when she gets pregnant in terms of stores, etc. If she were anemic, I would give her iron. But I'm not really sure giving any more supplements is going to be of too much value to her. I'm not a big fan of giving 5 or 6 supplements or even 2 or 3 supplements. I'm a very basic IVF person. I give only what is required really, gonadotropins, antagonist and HCG, 1 injection and progesterone. That's about it for my prescription. Jyoti, having said that, you will have to excuse me now because I'm in Jammu and I need to go for my physical CME in some time.
Oh, sir, one last question from you before you leave, because we wanted to cover up immunological part from you. What all vaccination they have to complete and all before starting the IVF, what all you want to see in them, in the rubella and everything, whatever. So briefly.
Right. Yeah, sure. Thank you very much. Essentially, before they start any kind of treatment or even as part of preconceptional counseling, it might be a good idea to ensure that she has kept up with the universal immunization protocol. But particularly in view of the fact that she's going to get pregnant, screening for rubella and then vaccinating her for it is certainly a good idea, as is screening her and vaccinating her for at least varicella and given the current climate, influenza. I think these are the basics, but if she could also be vaccinated for hepatitis B and HPV, it would really make for a happier situation in the pregnancy. Of course, nowadays you cannot miss saying that she should ideally have had the 2 doses of the COVID vaccine and the booster dose, ideally before she gets pregnant. However, nothing in the infertility treatment or early pregnancy or even late pregnancy should stop her from accessing the COVID vaccine. So, I mean, these are the basics. It's important to note that you can't use live attenuated vaccines in fertility or in pregnancy. Any other vaccine is quite safe, even if she gets pregnant. So if you're going to immunize her for rubella, I think it's important to also make a note on the paper saying that I have given you the rubella vaccine and it's a good idea for you not to conceive in the next 2 months because there is a risk of the child being affected by the live attenuated virus and therefore might have some abnormalities which may very rarely even need a termination. So I think that would really make for a good immunization history as well as doses before she gets pregnant.
Sharda Jain ma'am, is there a cervical cancer vaccine campaign we are running, sir, in Delhi? So we have to also see that she has taken the cervical, she has done her HPV and we've done her LBC and we have done her with her.
No, I think, when she comes for infertility, the basic things are required because if you bore her with this cervical cancer vaccination or a cancer vaccination, I think that's not justified at that particular time. Okay. That's the way. And I think, Jaydeep, I take opportunity again to wish you great success in your endeavor this time. Okay?
Thank you. Thank you so much, madam. It's so kind of you to say.
This is on the behalf of everybody.
Yes.
Thank you. Thank you very much.
For this.
Right. Yes.
I'm sorry, ma'am. I have to leave. I'm in Jammu and I have a physical CME here in some time. So
we can understand that. We can understand that, sir.
Thank you, ma'am.
Thank you so much, sir. Thank you so much, sir, for joining. And best of luck, sir.
Thank you.
Thank you.
Bye.
Thank you, ma'am. Thank you, ma'am. Bye.
Ma'am, Sonia, ma'am, even I think what all you have very posh patients in your South Delhi. So yeah, do you give them something extra from the government?
Just the wine. No, tell me, yeah.
Okay. And about the counts, Dr. Manju.
See, you know what? Actually, the micronutrients are something that we don't have too much of evidence about. we are all giving them empirically, thinking that this might help and that might help. Some amount of evidence is there. But if you want very well-designed studies, they are lacking. So therefore, if you are giving it also, maybe it is, see, like now we have this, we have myonisotol as one of the micronutrients, I would say, or one of these products which are being used very frequently. And initially we said there was no evidence at all, and so we were just using it empirically. But gradually the evidence is building up. We are also having randomized trials on myonisotol available on the internet now in the journals. So they may not be very, very good, but whatever it is, whatever we have, does seem to be saying that it is helping. So I think, again, the problem with nutrients is that every patient doesn't need it. You have to be selective in the kind of patients that you are picking up for that. And for that, those subsets are yet not defined for anything. There are no subsets of patients that have been defined for any kind of micronutrient. I remember when zinc was introduced in this country, that man from American Sharing, that company was called, he used to come with 2 bottles and put one in one glass and in the other and make us taste it. So he used to say, if it is bitter, then you don't have any zinc deficiency. But if it is tasteless, you have zinc deficiency. So you have to give it to your patient. So something like that. Now we know that in COVID, there is so much of zinc deficiency. We have found it. So we really don't know. And therefore, as Dr. Tank said, Dr. Jaydeep said, it's like burdening the patient with too many things, and it increases the cost of the whole treatment. So if you think it is justified, and if you have some kind of a proof to say that, okay, this might help, then yes, go ahead and give it. But otherwise, I don't think even a very posh patient will not like her bill to be thousands. If she is going to buy a Gucci bag, okay, but not when she has to buy Lycored.
Medicines, yes. Dr. Banker, sir, I'm sure doesn't give all this, because he gives very minimal. So what do you say, sir?
My prescription only contains 5 milligrams of folic acid. That's it.
Okay. Yeah. And Dr. Brigadier Sharma, sir, what Sharda Jain ma'am raised.
Doctor, I think, I definitely take time to give them about the diet. And I always say that 70% of your diet should be fruits and salad, and curtail as far as wheat, maida, and suji is concerned. And you can eat whatever you want. Evening meal should be lighter. I never give any supplements but this folic acid.
Right. Dr. Manju.
Now, next question to Sonia ma'am. We have a whole lecture on stress, on what is the stress and what is the impact on IVF and conception and all. Now, ma'am, we want to know your opinion and your expertise, thoughts on this. What is the effect of stress on pregnancy and conception, and what are the small tips we can give to the patient or couple to make themselves like cool and calm and to go through the procedure? So what is your experience in this?
I don't think there is a lot to be said about that, because Seema has very, very nicely said everything. She has really done a wonderful job. But having said that, everybody is stressed. Who is not stressed? Even the doctor is stressed. You are sitting in front of her and you are promising her just a 30% result. You're also stressed. You don't know what to say, and you don't know whether she is really going to make it or not. So that part is there, yes. But there was a very interesting study that was done in patients of infertility, and they compared them with the stress of cancer patients and heart disease. And they found that the stress in infertility patients is not anything bigger than the stress of cancer and heart disease. So, that is my take on having a counselor for infertility patients. I always feel we have been asked to have a separate counselor for infertility patients. Why not for cancer? Why not for heart disease? Everything is stressful, and they are actually, that is a life-threatening condition. Here we are just trying to make them pregnant. But there, if there the counselors are the doctors, here also we are the counselors. Only thing is, yes, that in order to have better performance, I think as Seema suggests, we should be a little more aware of the methods by which we can treat that stress. And the most stressful part has been found to be the 14 days after the embryo transfer to the pregnancy test. Those 14 days are the most stressful in all the studies. They find that the stress levels really go up. And that is something that we must never forget. And because during those 14 days, we are not in contact with the patient at all. We just left them on their own. In the first part of the IVF cycle, they are coming to us every second day with the hope that they are going to get pregnant. In the second part, we've just left them alone, and now they are waiting, and so are we. So I think that part has to be, they have to be more engaged in that part, wherein their mind can be diverted. And as she suggested, all those methods, wherein you teach. So they have also suggested that you tell them to write, what if I don't conceive? What should I do next? What if I don't have a normal baby? So things like that, so that, they are prepared for the worst also. So this is my take on stress management. I don't know.
Ma'am, partly, yes.
Counsel.
Dr. Sharda Jain, ma'am.
Yes, ma'am.
We have made a policy that we will definitely get in touch with this particular patient 2 to 3 times,
Yes.
because I think, once this connection of the clinic is there, then the pregnancy test becomes negative, does not bother them much.
Absolutely. Absolutely.
I think this interaction in between is definitely required.
Absolutely, yes.
Right.
And madam, there is another suggestion.
Junior definitely contacts them.
And madam, I heard Dr. Firoza Parikh's talking about this in one of the CMEs. What they have done in their clinic is that the counselor, they are young, pretty girls that they have, 2 girls who actually take the history and the details of the patient. And since they are psychologists, they go into the nitty-gritty of all the stresses that they are probably having in the history itself, without letting the patient know that they are psychologists, And so after that, when they are prepared with all those, even the mental stresses, they come to the doctor, to Dr. Firoza and her team, and then they start the actual process. So I think that's a very good idea, because then she says we are better prepared to engage her in that aspect as well. So I suppose we probably will have to change our way of addressing these problems a little bit more. Rather than having special counselors, we ourselves are very good, I think, because at the end of the day, the patient comes back to us, Doctor Sahab, फिर भी आप बताओ, उन्होंने तो बता दिया, पर आप बताओ कि अब हमें क्या करना चाहिए. So I think we have to be the counselors all along.
Ma'am, continuing with your comments of a counselor, yes. You covered half of the question that we are going to ask you now. Now the role of the counselor in the clinic. And with the ART bill that has come, they say that every clinic has to have a counselor.
Yes.
Now, who can be a counselor? What are the qualifications of a counselor? Can my receptionist, who is very good at talking, convincing, sharing with the patient, can she be a counselor though she is only 12th pass? Yeah. And whether it has to be, yes, ma'am, I'll take your comments. I'm just asking certain queries. So who could be a counselor? Is a counselor must for every IRT clinic? And pre-conception, intra-conception and post-conception, whether success or failure, they have to be, whether every case needs to be counseled. So those are the questions, if you could please let us know.
Yeah, see, basically, counseling again has many aspects to it. One, of course, we are talking about stress and, psychological counseling. Then we have to counsel the patient on the treatment itself, on what it entails and what are the, the side effects and what all. And then, of course, comes the financial counseling to this patient. So there will be many aspects of this counseling. But I suppose what they are basically trying to talk about in the ART bill, and what was also there in the earlier ICMR suggestions, was that there should be a psychological counselor to counsel them for everything. And of course, for that, they had to have a psychology degree. That was the qualification identified then. Now, we do not know yet what exactly is required, because that will come probably in the rules and regulations which they will define. But as such, I suppose, your question, your answer to that is, if she has to just counsel them on what is going to happen, yes, the front office can be a counselor. But if she has to do stress counseling, no, she's not the right person. She's not the right person.
Okay, ma'am. Yeah. Dr. Jain, ma'am, you wanted to add anything?
I think, they had in ICMR guidelines, they had very categorically said there should be a specialist counselor. But I think if you read the bill, any staff can be trained into counseling. And I think, there are 3 aspects to it. One aspect is that, they must know about small things which they majority of the people who are infertile come to you for, maybe advanced infertility workup. They do not know many things. So I think, the procedures need to be told to them. And we have made 2 videos, they let them have a look at it, and then they have questions. We are free to ask them. Then secondly is that, madam has said financial kind of thing. But I think, about the procedure, they must know each thing in detail.
Absolutely.
I think that particular part has to be done. And what we have done is, we have made a structure kind of a thing. We have to only just tick, 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 tick. ये आपने counsel कर दिया कि नहीं कर दिया, ये आपने counsel कर दिया कि नहीं कर दिया. All things are important, I think, that's the first visit, that kind of a counseling is definitely required. I'm sure Dr. Sonia and you also must be finding it out. Any center, ART center you visit outside, 1 day is a counseling session and 2 to the clinic. That's it.
Right now. Coming on, Dr. Manju, over to you so that we can take our last question on genetic screening, and I think we will then call it a day.
Dr. Sharma and Manish.
Before that, Dr. Sharma and Dr. Manish will be answering that. Yes.
So there is a pre-pregnancy genetic carrier counseling. So we have one couple, the both partner are thalassemia trait, and they had a pregnancy.
Oh, you must ask Dr. Manish. He's actually produced the first baby. Dr. Manish, you must talk about that. Thalassemia.
Yes.
Thalassemia major. Yeah. So now they came to the IVF clinic and they want to know what all options are available to avoid this MTP again for thalassemia major. So do we have some options in IVF to avoid all this through genetic?
We certainly have, and I think this is something which is specifically permitted in the ART Act, because this is a disease burden which we can reduce. So what, if you look at the natural pattern of inheritance when both the parents have thalassemia minor, it will be that 25% of the offsprings will be disease-free, 50% will have thalassemia minor, and 25% will have thalassemia major. So what we can do through IVF is test the embryos and find out whether the embryos are affected, carriers, or they are normal. The same test which we would have done on a chorion villus sampling or an amniocentesis, we do on a trophectoderm of a blastocyst. So this begins by doing a mutation analysis of both the parents to find out where exactly the mutation lies. We then need to develop a probe which will detect this particular mutation. We create embryos, test the embryos, and we transfer only the disease-free embryos. Having said this, this also means that every embryo, only a small percentage will be normal. So again, depending on the patient's age and ovarian reserve, we need that many more embryos if the patient is likely to produce fewer embryos. So sometimes we have to counsel the patients that we might need to pool embryos from multiple cycles and then test them, so that there is a high possibility of at least one embryo being at least free of thalassemia major. The other thing which should always be done along with this is also the standard PGT-A testing, because no point in having a child which is thalassemia free but has Down syndrome. So ideally one should combine both the testings together. If you also have an affected child previous who needs bone marrow transplantation, then there is an option of testing the embryo for HLA status as well. But this is something which is still a gray area. We need clarification in the rules whether HLA testing on such embryos will be allowed or not. And again, if you want to do this as well, we need that many higher embryos. Studies have shown that if you want to do all the three, that is an embryo which is thalassemia free, normal on PGTA, and a HLA match, 1 out of 11 or 12 embryos will satisfy all the criteria. So we need that many more embryos. And in the case that we did, out of 18 embryos pulled from 3 cycles, we got 1 embryo. So, I mean, it does require a lot of patience.
A lot of embryos.
Yes, very well.
So, sir, if we don't get an embryo, then what do we do? That means adoption?
So, see, 2 issues. See, if you don't get a HLA matched embryo, they will at least get a disease-free child. If they don't get embryos which do not have complete thalassemia, at least they will have a thalassemia minor child.
Minor child.
To have a patient who does not have everything is extremely rare. Even if you have 5-6 blastocysts, at least one out of them will not have thalassemia major and will be normal.
Right. That was something very, I think we need to, in all these cases where we have thalassemia or we have Rh negative as well. Rh negative pregnancies also, sir, have you have any
Yes.
Not on Rh negative, but we have done this for many disorders like spinomuscular atrophies. So any monogenic disorder which has a recessive or a dominant transmission, for which you are able to identify the mutation and develop a probe, you can offer PGT-M.
So first that means detect the mutation in the both the parents.
Yes.
And
See,
develop
unlike
that probe and then
if you look at PGT-A testing, it does a karyotype screening of all the 46 chromosomes. So any problem in any chromosome, you will detect. Unlike this, PGT-M is a specific testing for a specific disorder. It is not that you order a blanket screen that do PGT-M and tell me the child is disease-free. So the first step is to identify what you want to look for. Unless you know what to look for, you cannot look for in PGT-M.
right. Anything else, Dr. Sharma, sir? You would like to add anything? Otherwise,
I think he has done and give us first-hand information with what he has done. I think
right.
I don't have anything more to
Absolutely.
add to it. But definitely, genting counseling is a part of our counseling, and whenever a couple comes, we should also, especially the Muslim couple is there about the consanguineous marriage and all, we should find out and then talk about that.
And plus, I think this requires a lot of time because see, probe development will take 4 to 6 weeks. Then sometimes we have pulled up to 6 cycles of IVF to produce one child. So it is basically a year-long process for some couples. So a lot of patients, it is expensive, but compared to the other options of doing, a commercial bone marrow transplantation, this was fairly cheap.
Yeah.
That's painful also.
So many cycles, at least 5-6 IVF cycles, and then the PGT-M. So it definitely costs, but at least they can have a healthy child. So at the end of the tunnel, there is a light to this dark tunnel. So I think that is it with a 1.5 hour of discussion on a very basic topic today. I think we still have gained a lot from all our esteemed panelists, and I, along with Dr. Manju, would like to thank you all our dear panelists, respected Dr. Pai sir, though could not join, Dr. Jaydeep, Dr. Sharda Jain ma'am, Dr. Neeta ma'am, Dr. Banker sir, Dr. Sonia ma'am, Dr. Sudha ma'am, and Brigadier Sharma sir. Thank you for giving your precious time and joining this platform. Thank you so much. And thank you, Dr. Seema. Wish you all the very best. And
Seema is going to win, don't worry. Thank you.
Thank you so much, ma'am. And I really loved the discussion.
Thank you.
Thank you, sir.
Manish, and Dr. Manish, are you pooling embryos if it's not happening?
We have to pool embryos. We have to pool because see, the biopsy is a one-time cost, irrespective of the number of embryos that you send for biopsy. So we have to pool till we have sufficient number of embryos.
Yeah.
Yes.
Today I saw a patient conceived at your center in Surat. Second time they have transferred here, so I'm going to see.
So thank you, Jagsonpal, and over to you, Ankit.
Yes, ma'am. Yes, there will be a small.
One word, Ankit. We don't want any more webinars from Jagsonpal for at least 2 weeks, and Jyoti also.
Thank you.
No, ma'am. Jagsonpal is continuously here.
Sonia ma'am, it was so sweet of her. She did it for me within a week.
So
Love
sweet.
you, Jyoti.
I'm joking.
Thank you.
Thank
Sonia
you.
ma'am, it seems you're having headache or something.
No, nothing.
You're looking tired. So are you?
No. वो तो वैसे ही. No. Thank you.
She was thinking what else I should.
And you know what?
It's so funny. Every week she comes up with a new thought and a new webinar. This Jyoti.
I'm abhi Saving Mothers है 27th.
Yes, ma'am. Yes, 25th and 27th.
25th, 27th.
Yes,
So we
ma'am.
have two big webinars.
Manju, you were awesome, dear. I just heard you for the first time.
Yeah,
Are we
Manju.
offline? Are we offline?
No, we are on.
Yeah. Now we would, I think, no. So we would say bye to each other and thank you so much,
Thank you so much.
Thank you all the participants who joined
No,
today.
but he hasn't said his word. Let him speak.
Yes, ma'am. A word of thanks from our side, ma'am. So, Amit, sir, please.
Jagsonpal Pharmaceuticals Ltd proudly presents PRORETRO micronized dydrogesterone tablet 10 mg. Jagsonpal Pharmaceuticals is manufacturing all the active pharmaceutical ingredients and intermediates concerning dydrogesterone, making India self-reliant. Atmanirbhar Bharat. Vocal for local. Go for PRORETRO.
A very good evening to all the esteemed faculty and attendees, attending doctors. Indeed, it was a very wonderful session. So on the behalf of sales teams of Naari division of Jagsonpal, I, Ankit Dogra, from Medical Services, seek your support for PRORETRO 10 mg tablets of micronized dydrogesterone for luteal phase support in ART, recurrent pregnancy loss, and threatened abortion. We thank you for this opportunity to connect with you all today through this webinar and are proud to present PRORETRO 10 mg tablets of micronized dydrogesterone, API of which Jagsonpal is manufacturing now. After years of R&D, we make all the quality API of dydrogesterone with intermediates, making India Atmanirbhar for producing this critical API. The quality of a brand, PRORETRO 10 mg, is backed by the bioequivalence study to prove its clinical efficacy and safety. Moreover, with the clinical advantages of PRORETRO in assisting motherhood delivering happiness, our indigenous API is available with a remarkable reduction in the cost to the patient, providing a more economical therapy at just 50 rupees per tablet. PRORETRO is readily available at all the counters near you to prescribe. Our sales team visiting you is continuously striving to make your bulk purchases experience effortless and worthwhile. Looking forward to your support to our newest brand in the product portfolio of Jagsonpal, PRORETRO. We look forward to your presence to our further programs as always. Join us this Friday and Sunday for a 2-day conference by Haryana Association of Obs and Gyn for workshop and CME on saving mothers. Please note down the Zoom ID displayed and register now. Thank you very much.